Hello, good afternoon, everyone. It is yours truly, Dr. Pierre, your favorite board certified internist, founder of drpierresblog.com, podcaster, best-selling author, and I'm bringing you another edition of the Lunch and Learn, and I'm excited. This is episode 45. Most importantly, this is my first official live stream, especially for the Lunch and Learn from the office. I know I did one earlier when I came in, but this is, we're actually going to be learning something today, so very excited. We're going to do some quick, housekeeping things. Everything's different too now. As you can see, my background's different. I have my computer's not in front of me anymore. It's right to the side. So I'm just going to go ahead and share the post. And if you get on while I'm waiting, go ahead and share the post as well. Today we're learning about diabetes and very excited to talk about that extremely important topic, which I don't even understand how I haven't talked about it yet. I'm not even sure how it fell through the cracks, but it did. But that's okay, because we're on episode 45, so we'll get back to it. So let me just go ahead and share the post on my personal page, and we'll get started. Okay, all right, so we are started. We're live again. It's officially on my page now. Again, you're truly Dr. Pierre, your favorite board certified internist, and we're going to talk about diabetes today. And why are we talking about diabetes? For one, it's probably one of the most important disorders that me as an internist run into on a daily basis. And for those who have been keeping up and have been following me from the beginning, now I'm in a different location. I'm a different job place, and now I do inpatient medicine, which is totally different ball game from when I was my outpatient clinic, but we're seeing a lot of the same disorders. If you remember correctly, when I was an outpatient physician, one of my mantras was really to try to quote unquote bankrupt the hospital, right? And a goal of mine was to keep those patients on an outpatient basis so they don't end up seeing me here on an inpatient basis. So now I deal with a lot more acute care. I deal with a lot more patients who are sick, and I deal with those patients who, if they would have had maybe some proper follow-up, or maybe not, they wouldn't be here at this time right now. So we're going to talk about diabetes, because this is a topic, again, I'm not even sure how I got 45 episodes in without talking about diabetes. It's very, very surprising, but here we are today. So we'll start with just, what is diabetes, right? Diabetes is the body's ability to use a hormone called insulin, and I'm going to talk about what insulin is in a second, to break down and use what we eat. And by eat, I mean carbs, I mean fats, I mean proteins. So when a person is diabetic, they've actually lost that ability to either, one, respond to insulin or use insulin to its best ability, right? So that's kind of the umbrella when we talk about diabetes and diabetes in general. And when we talk about diabetes, you can't talk about diabetes without talking about how important insulin is. And insulin is a hormone that's produced by a pancreas, which is a very major organ in our body, located in our abdomen, which produces insulin. And insulin's job, again, is to produce and regulate how our body breaks down fat, regulate how our body breaks down proteins, regulate how our body breaks down carbs, most importantly. Because when you hear people talking about insulin and you hear them talk about diabetes in general, first thing they always talk about is the sugar, right? How's the sugar? And I think a lot of it is, hoopla is made up, not even hoopla, but a lot of the emphasis on diabetes is always focused on the sugar. But when I have patients in my office, a big thing I get on them is understanding that, we have to monitor everything. We have to monitor not only your carb intake, because that's what, will directly, and I say directly, break down into sugar, but we got to manage your fat. We got to manage your protein intake. So all of these three components of our diet play a huge role in, being able to, one, control diabetes and make it so that it doesn't become a rampant disorder that, one, you end up seeing me in a hospital for, right? Me a few months ago, right, was my goal was to keep on an outpatient basis. Hey, Porto, thank you for joining. Me on an outpatient basis, my goal was to, keep you guys away from the hospital setting, because we know some of the risk of diabetes, especially in the long run. And we'll talk about some of the complications, what happens with a patient who doesn't, have diet, who doesn't control their diabetes, right? For example, diabetes is a very major cause of blindness, especially for patients, the age is about 20 to 60. It's one of the leading causes of patients being on dialysis. And for my patients who know, especially my dialysis patients, my diabetic patients, especially when I get them early, I always go in this little rant. And I always say, diabetes, top 5 cause for patients to suffer a heart attack, top 5 cause for patients to suffer a stroke, top 5 cause for patients to be put on dialysis, top 5 cause for patients to get blind, top 5 cause for patients to get amputation, right? And if you have any family members, or any family members who don't have their toe, don't have a foot, don't have a leg, how important, right, diabetes is. Hey, thank you for joining. That was one of my good friends there as well. So very important, right, when we talk about diabetes, the sheer importance of control, right? Because in the initial stage we think about sugar, but especially from a clinical standpoint, right, diabetes is a vascular problem, right? It's a vascular problem for me, because I know if I don't control your diabetes, I know what happens in the long run, right? So and we always I'd like to get you guys when you're young, right? Because when you're young, it's much easier to control. It's much easier to say change your diet. It's much easier to say maybe eat this food versus that food. My older patients, especially the ones who are newer onset diabetics, it's like moving stones, right? When you say, well, all of a sudden, you can't eat this, all of a sudden you can't eat that. And I'll tell you what, because I'm a Haitian, right? So whenever I have my Haitian patients who I diagnose with new onset diabetes, the first thing they tell me, Dr. Pierre, you're telling me now I can't eat rice. Because as a staple in a lot of our diets, right? It's rice and something else, right? So once they hear that I tell them they're diabetic, they automatically assume I tell them you can't eat rice. And that's just further from the truth, right? Diabetes and control of diabetes, a lot has to do with more portion control than anything else. And my dietitian, my nutritionist folks can definitely tell you, yes, we focus on maybe try to eat less of, maybe say white rice, but we don't want you to give up rice in general, right? So very, very important to understand, diabetes is not just a sugar disease. It's a disease that causes problems, all across the board, right? There's probably, I can't really think of a medical specialty that does not run into a patient with diabetes, whether it be from complications or something else from that standpoint there. So definitely important to understand that, when we talk about diabetes, especially in the initial frame, right? Dr. Daphne, thank you for joining. That it's surely important that I try to stress that fear. Like I said, when I get you first in the office, I'm telling you, I'm saying, if you don't control your diabetes right now, your foot's gonna get cut off, you're gonna get a heart attack, I'm gonna put you on dialysis. I try to, I really try to hit them with that scare tactic so they can kind of understand, what lies ahead if they don't, right? From a numbers game, right? So let's just talk about a numbers game when we talk about diabetes. People who are diabetic spend twice as much on their medical care, right, than someone who isn't diabetic. Twice as much, right? You are twice as likely to be in an emergency room if you're a diabetic, right? So think about that. You're 2 times, just because you have the diagnosis of diabetes, you are 2 times as likely to end up in an emergency room for a whole slew of reasons, right? And when we talk about, today I'm going to talk about type 1, type 2, and gestational diabetes a little bit. So just to give you a kind of understanding of when do we start diagnosing diabetes in our patients, and when is it time to get your butt in gear from that standpoint. In the grand scheme of things, diabetes, I was looking at the numbers, about $250 billion is spent every year on diabetes and diabetes related issues, right? About $70 billion a year is spent on lost productivity. So that's a person who and I hate to say patient with diabetes, there's a person, everyone's a person, right? There's a person who can't go to work because of diabetic complications. There's a person who gets sick because of diabetic complications, because when you're diabetic, you actually have an increased chance of being sick as well too, right? So, I like to caveat, my diabetic immunostate is less than a person who does not have diabetes, right? So it's extremely important, right? Especially, I know it's not cold, I know it's not flu season right now, but I stress the importance of all my diabetic patients. I don't care how old you are, should always get a flu shot every single year, right? Because you are immunocompromised, right? Which means your body does not fight infections as effectively as someone who does not have diabetes, right? So that's important, right? So again, when we stress about diabetes, it's not just a disease for the sugar. It's not just this. When I hear diabetes, I'm thinking about all of these like long-term effects that I got to worry about, right? So it's definitely something to make sure we're very keep an eye on, right? In the U.S. alone, about 30 million people have diabetes. About 30 million people have diabetes in the U.S. alone. About 10 to 15% of those people who have type 1, and the rest, right, a huge majority, about 80% or so, have type 2 diabetes. And we'll talk about the two differences in a minute. And it's the 7th leading cause of death in the world. 7th leading cause of death in the world. And honestly, if you ask me, it's probably under diagnosed, because for a lot of times when I talked about diabetes being top 5 cause for heart attacks, top 5 cause for strokes, top 5 cause for patients being dialysis, top 5 cause for patients to be blind, top 5 dialysis to get your foot, arm, toe cut off. Like when I say all of those things there, diabetes causes a lot of those problems that it doesn't even get the blame. So we blame this. Oh yes, so especially for my men, that definitely is very true. Impotence is very important, right? Because remember when we talked about, diabetes is a very vascular problem, right? So what causes you to get an erection? A good vascular system, right? So if you're a diabetic, and especially for my men out here, right? So we've talked about this before. For my men, the most important way, probably the top ways to get my men to do something, is to say that it's either going to affect their sexual health, or you have a partner who says, you need to get it done, right? So sexual health and a partner or family member getting on them is usually the top 2 ways that I see men in my practice, right? So if I tell a man, if you don't do nothing about this diabetes, you will have problems with erection, and this is the problems that Viagra, Cialis, and all these other medications are not going to cover, right? So extremely important, right, to control your diabetes in all facets of life, right? You can't run away from, being diabetic, right? And we have very classical symptoms, right? Very classical traits that can kind of lead, especially us physicians and medical students and residents maybe watching, that leads us to oh, this person may be diabetic, right? I have patients come in my office, hey doc, I've been eating like crazy, I've been drinking like crazy, I've been peeing like crazy, and I'm still losing a lot of weight, right? In addition, oh, definitely. Most important, definitely a vascular problem, right? So diabetes. When you think diabetes, don't think sugar, think vascular problem, right? Because to me, that's where I go with on that standpoint there. So we have so again, I have my patient who comes in. They're eating a lot. They're eating like crazy. Eat anything under the sun. They're always hungry. They're always drinking something. They're always peeing. But for some reason, they're losing a lot of weight, and that's a very ominous sign for me, right? That this patient, not only are they a diabetic, but they are very uncontrolled diabetic. And I used to have patients who I know are diabetic, and they come in and it's like a 15-pound, 20-pound weight loss. And I say, oh, wow, I see you lost some weight. Well, yeah, doctor, the weight's just kind of melting away. And when that already tells me they probably not taking my medication like I told them, and that their sugars is running out of whack. Because when your diabetes is so uncontrolled because remember I talked about insulin. Insulin helps you break down fat, helps you metabolize carbs, metabolize protein. If your diabetes is uncontrolled, you're not doing none of that. So your body, whatever you eat or drink, is going in and out, right? So that's the problem. Don't disregard that. That was like a spam call. So I don't want nobody to think I'm like ignoring like my hospital calls from that standpoint there. So extremely important, right? When we talk about diabetes and some certain signs and symptoms of diabetes, to always to be on the lookout for it, right? So now we're going to split it up, right? So we know we have a good grasp, right, of what diabetes is. So we're going to talk about type 1, we're going to talk about type 2, and we're going to talk about some gestational diabetes kind of, in the grand scheme of things, right? So type 1 diabetes used to be called insulin dependent diabetes in the old days, and we stopped calling insulin dependent diabetes because when we talk about type 2, we started realizing we have a lot of type 2 patients, and especially in my old practice, I had a lot of type 2 patients who also had to be on insulin as well. So we started calling it juvenile dependent. Unfortunately, in this day and age, we can't even really call it juvenile dependent no more because we have a lot more older patients who end up developing like diabetes as well too to this type. So type 1 diabetes is caused by the body's inability, right, to even produce insulin, right? So your body is not even making that hormone that's going to help you break down the carbs, fat, and protein that helps regulate the sugar, right? So it's not even making it. And a very common cause that it doesn't do that is because your body attacks itself, right? And we, in the medical world, we call that an autoimmune disease, right? Your body attacks itself and your body just cannot produce any more insulin. So your body produces 0 to none insulin whatsoever. Hey Jen, thank you for joining. So autoimmunity is a major cause for patients to have type 1 diabetes, right? And when I test these patients in my office, a lot of them, which I don't do it very often, but a lot of them will have antibodies for type 1 diabetes. They'll have those antibodies that I know that normally will attack its own pancreas and cause it to stop developing insulin. And again, remember we talked about how important insulin is. If you don't have insulin, you can't metabolize your proteins, fat, or carbs. So remember, like when we talk about diabetes, 2 things I want you to connect: how important insulin is and how important it is from a vascular standpoint. We know about the sugar, right? We know about sugar. And sugar gets like the popularity of it, but we got to understand that it's, when it comes to diabetes, vascular issues and insulin are like 2 very important factors from that standpoint there. So when we talk about a patient who cannot make any insulin, right? So this patient is not making any insulin. It's the reason why we tend to call it like a juvenile onset, which pretty much means if you're getting diagnosed with type 1 diabetes, you're usually going to be presenting unfortunately in the hospital, right? Because it's usually something that, this patient, it's a little kid, right? They don't really know no better. They eat a lot, they're drinking a lot, they're peeing a lot. They don't know that they have a problem, and they actually end up in the hospital, right? So they end up seeing someone like me in the hospital because their sugars are so out of whack. And I've seen patients, for example, just to give you an idea, a normal blood sugar is from 60 to 100. I've had patients in my hospital that are 1,000 and above, just to give you an idea, right? And your body cannot clinically tolerate blood sugars that high. So just to give you an idea, right, 60 to 100 is a normal. Patients, especially with my my type 1 diabetic patients, patients are walking in here, blood pressure 600, 700, 800, and the only reason why we know is that 100 because a lot of my patients, if they tried to stick themselves, the glucometers that you get at these stores, grocery stores, and everything else, they don't even read that high. They'll just say too high, go call a doctor. They won't say call a doctor, but they'll say too high. So usually most of those machines stop working, I think, at about 600. So after 600, they don't even tell you what a number is, period. They just say too high, can't read. So just to give you an idea of how sick these patients are. And these patients come acutely ill. A lot of them end up having to be intubated at first because when your blood sugar is that high, what happens in your body is you actually become acidotic, right? So you actually almost become like an acid pit in your system, right? And you can't breathe, you can't eat, like you're just extremely sick. These are some of your most sicker looking patients that you'll probably ever see in the hospital are patients who come in because their sugars are uncontrolled, right? So extremely important, right, to recognize the symptoms early. But I can tell you, especially for most of the kids who get diagnosed, a lot of times they're getting diagnosed in the ER, right? By the time they realize something happened, they're already in the ER. And type 1 diabetes affects males more than it affects females, and it affects in this age group kind of stays the same for all the diabetes as far as which population. Hispanics, African Americans, Native Americans, right, are hugely affected by diabetes as a whole, right? Like top three categories of groups that are affected by diabetes in general. And their complications, like we talked about, extremely elevated blood sugars. They have an increased risk of infection because of the diabetes, and then all of those other problems that kind of go awry. So I do stress the importance, especially in for my parents who have kids, and to be on the lookout for those signs and symptoms, right? Be on the lookout for those signs where your kids are just eating and drinking everything. And I got almost a 2-year-old son. He eats everything. So I'm not talking about that, but because usually they're more teenagers when they're getting diagnosed. Usually like between like 10 to like 16 is when they're ending up in the hospital for it. So it's not something that like happens very quickly from a standpoint. But always be mindful, always following up with the doctor. If you see that, my kid is eating everything, drinking everything, and like, I don't know where it's going, always keep on the back of the mind that maybe like diabetes may play a role in this factor there, right? So we're going to talk about, so now we're going to segue to type 2 diabetes, right? So we talked about type 1. Type 1 affects about 10 to 15% of the population, type 1 diabetes. This is, again, where the body attacks itself and forces it to stop producing insulin whatsoever, right? And what's the result? Your sugars skyrocket high. Your body doesn't know how to deal with those extremely elevated blood sugars, and then you kind of go from there. So now we're going to talk about type 2, right? Type 2 is easily the most common form of diabetes, right? And we used to call this non-insulin dependent diabetics, but as I've seen, especially over the years, especially in my practice, I have a lot of type 2 diabetic patients who have to end up going on insulin, right? And a lot of it is just because of lack of control. They're just not controlling. They're not, eating like they're supposed to eat. So they are uncontrolled diabetics who it gets to the point where the regular medication for treatment does not even help it, right? So your type 2 diabetics, pretty much from a symptom standpoint, elevated blood sugars, peeing a lot, drinking a lot, eating a lot, those are the big thing. But the main cause of those patients is not that they don't produce insulin. For many of them, they don't produce enough of it, right? So they may produce enough insulin where, your body doesn't, go to like 1,000, but your blood sugar doesn't go to 1,000, but maybe it goes to like 600-700, which is still extremely too high. And what I'm going to start doing, especially now because I'm in more of the hospital setting, I'm going to tell you a lot of the hospital complications that I tend to see. For my type 1 diabetic patients, those patients will go into what we call diabetic ketoacidosis. Boom. And a lot of this information I am going to put on the blog as well. So you'll see a little link on the blog for an explanation of a lot of these things I'm talking about. And for my type 2 diabetic patients, they will never, ever go into diabetic ketoacidosis, right? They will never become so acutely acidotic because of the diabetes. And the big reason why is because, remember, I said it's not that they don't produce insulin. It's not like they do not produce it at all, like my type 1 diabetics. They just produce it at a rate that cannot keep up, right, with either the normal diet, the person's diet, or it just can't keep up. And sometimes they even produce insulin that just isn't really as functional. So they may produce maybe on a total wise a good amount, but it doesn't even work well. So it's pretty much the same thing. But they produce enough of it so their bodies never go into DKA. Their bodies never go into diabetic ketoacidosis. They actually go into a disorder we call in the hospital setting called HONK, which is I think like HHS as hyperketotic hyperosmolar syndrome or something in that regard, right? And what we've seen, especially in patients who come in HONK or patients who come in DKA, dehydration is a very big factor in them, right? And you would think, and I talked about like how serious the patients are when they go into like the DKA, like you think that would be the bad thing, but when we talk about from a dehydration aspect of it, if my DKA patients are, let's say, 3 liters of fluid behind on just, behind on fluids because they've been peeing and drinking, they've been peeing everything out, your honk patients, your type 2 diabetic patients who end up in the hospital, they may be like 6 to 7 liters, right? They are like severely dehydrated, and on top of with all of the other medical issues that kind of come along, right? So extremely important, right, to very, 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 very well monitor like your patient, especially yourself when you're a diabetic, because that can happen, right? You're just drinking, peeing, and you just start peeing much more out than you're drinking in, and that's when the problems arise. And there's a lot of different disorders that can put you into like these states. Most of the cause is usually just non-compliance, like you're not taking your medications, or you don't have medication because maybe you can't afford your medications. And infection is a big one too, right? So infection and not taking your medications are like some of the top causes to end up in the hospital, right? Hopefully, like I said, hopefully my goal is my patients or people who watch this, right, never end up in the hospital, right, unless it's for like an elective procedure, right? Because I think the first thing is just being educated and getting to the point where you don't need to, you can kind of cut a lot of these things off at the pass. So when we talk about diabetes, again, sorry to segue. Talk about diabetes and type 2 diabetics. Those are the patients who do not make up enough insulin. They just don't make enough insulin to kind of keep up with the demand. And because of that, they are not necessarily, bound to need insulin like for the rest of their life, like my type 1 diabetics. But if it becomes uncontrolled, they end up needing it like after a while. And a couple of causes, a lot of it is genetic, but a lot of it is just environmental as well, right? So these are patients who and we tend to diagnose type 2 diabetes at a much later age, right? And before, when I used to say much later age, I would be thinking about 35, 40, 45, 50. But because of what's been happening, especially with the epidemic of obesity, we're diagnosing a lot of children with diabetes, type 2 diabetes. Remember, before we used to only diagnose type 1 in children, but we're diagnosing a lot of children with type 2 diabetes just because of like how severe obesity has been running amok. And very common like risk factors, I would say, especially for your diabetic patient, especially type 2, is anyone who has a history, right? A family history of type 2 diabetes is, definitely concerning, right? I always ask, especially in my office, I always ask, do you have anybody in your family who's a diabetic? Because that can lead you to be concerned that, you may have diabetes as well. We talked about, being Native American, being Hispanic, being African American, just having that tagged on you is a risk factor for being a diabetic as well. Patients who suffer from high blood pressure, patients who suffer from high cholesterol have a risk of being diabetic as well. And for that's more of a genetic component. Because if you think about it, let's say you got the tree, right? Let's say from here to here, right? On the genetic tree, like high blood pressure may be here. Right next to it is high cholesterol. Right next to it is diabetes. Right next to that is obesity. So from a genetic standpoint, so that's why it's not surprising or shocking to us that if a patient has high blood pressure and high cholesterol, or high blood pressure and diabetic, or all of these kind of combined. Because from a genetic standpoint, we've seen studies that shown that genetically they are pretty like similar and pretty close together in proximity. So if one is activated, it's not shock if this one over here is activated as well. From that standpoint, so extremely important to be very mindful of diabetes, especially in type 2, because there's so many more people who suffer from type 2. Again, about 85% of your patients who suffer from diabetes will likely have type 2 diabetes, right? So that's a huge risk factor for us, moving forward, and even when we're thinking about that. And I think, we're talking about gestation. Gestation is my last one, right? So gestational diabetes, this is a patient who becomes pregnant, and they end up being diagnosed with diabetes, usually within like the first trimester. I think that's when they usually do that test. And for pregnant patients, even my wife actually had gestational diabetes as well with our first child. And they make them drink this like sugary drink, and they test you after 1 hour to see what your blood sugars are. And because when we talk about diabetes and we talk about like the actual diagnosing of it, there's certain numbers that we look for, right? There's certain numbers that we look for. Like for a person who is diabetic, like how do I classify you as a diabetic? Is if your blood sugar, like if you're fasting, 8 hours fasting, and I check your blood sugar and it's over 126, you are what we call a diabetic. For a patient who drinks that drink I was talking about, if their blood sugar stays above 200, you are also going to be like diabetic, right? And for patients, and regardless of when you eat or drink, if I happen to check your blood sugar at any time of the day and it's over 200, you're diabetic as well. Because your body has such a system. Like I said, because I'm not diabetic, right? I just ate lunch, right? I could just eat lunch and then 5 minutes later, you can check my blood sugar. My blood sugar will never be near 200, right? Because your body says, oh, this person's eating something. We need to raise the insulin to make sure that that sugar doesn't like stay around. So for patients who, are walking around, random stick tests on the finger, boom, you got a blood sugar 200, or random blood tests when they go to these health fairs, which I recommend everyone go to the health fairs, because one, they're much more frequent than usually by the time you see the doctor. Two, they're usually free. So, you're getting blood sugar checks, you're getting cholesterol checks, and all those other things kind of under the sun as well. So when you get some of these numbers here, that's a very clear diagnosis. Boom, this person has diabetes. So you have this patient who is pregnant now, and this is a person who did not have diabetes before. A person who did not have diabetes before, who now has diabetes. So for your patient, and gestational diabetes, accounts for about almost like 85% of patients who are diabetic while they're pregnant are due to gestational diabetes, and that's just due to increased demand from the baby and everything else from a genetic standpoint. There's some genetic factors that kind of play a role in it. So what's the problem with gestational diabetes, right? What is the concern, right? For your gestational diabetic mothers, right? The concern, especially, let's say concern for the baby. The concern for the baby is that the baby can come early. So like preterm birth is very common in patients with gestational diabetes. You can have a very big baby, so your baby, because you're having all of these elevated blood sugars, have excessive birth weight, right? So that's a very common thing that we tend to see as well. So when you see like these news articles of this person had a 10-pound baby, 12-pound baby, 13-pound, like crazy numbers, just know that the mom was gestational diabetes. Like already, you don't even have to think about it. You learned that today if you didn't know. Like if you see any of these like crazy numbers for a baby, especially when we talk about weight standpoint, just know that the mother had gestational diabetes, because that's usually the only way you can get it to that severe. And even though we talk about gestational diabetes and blood sugar being out of control, a lot of times we have to run the risk of checking your baby just to make sure that their blood sugar isn't too low, because a lot of times the insulin that you're taking, especially to treat your diabetes throughout your pregnancy, causes your baby's blood sugar to be low. So that's a couple of things as well. So, but what's the concern for the mom? Concern for the mom is, one, now that you're a diabetic, now we have to worry about blood pressure control being an issue. Now I have to worry about preeclampsia, which is an emergent issue that causes a lot of preterm births. So now you can see where that becomes connected. One, you have a baby that's too big. Then you have an increased chance of having that baby early. And then three, you have an increased chance of causing harm to the mother that causes you to have that baby to come early, right? So all of these things, again, when we talk about diabetes, right, it's like I said, I've said this before, I would not wish diabetes on my enemy because of all of the things you got to worry about, right? A lot of things you got to worry about when it comes to diabetes. And for some mothers, and I'm not sure what the numbers are, but for some mothers, they end up becoming diabetic afterwards, right? So the baby they weren't a diabetic before they got pregnant. They got pregnant. Baby was here. While the baby was here, they had gestational diabetes. And then after the baby left, the diabetes never went away. So it's a very common thing to deal with, especially in your diabetic patients, right? So that's that's the three, right? So we talked about. So what did we talk about today? We talked about what is diabetes, and why is everybody so gung-ho for it, and making sure we're treating it right. We talked about, oh hey, Dr. Mather, Dr. Poon, med school classmate. We talked about why is insulin so important in diabetes. We talked about 3 types of diabetes: type 1, type 2, and gestational diabetes. There's a few others, but from a numbers game, those are really the three that we like to go about and, like really be after from the standpoint. We talked about some of the biggest risk factors, right, for your diabetic patients, right? And, again, I'll tell you my top 5 rant. Top 5 cause for a patient that suffer a heart attack or coronary disease. Top 5 cause for a patient to suffer a stroke. Top 5 cause for patients to be on dialysis. Top 5 cause for patients to become blind. Top 5 cause for patients to suffer an amputation. And honestly, when I talk about dialysis and amputation, like diabetes is probably like number 1. Right. So again, when we talk about diabetes, when you hear diabetes, from now on, I want you to think blood sugar. That's okay. But I really want you to think vascular problem and insulin, right? So those are the 2 things when you hear diabetes. That's really what should be the eye. Like the blood sugar is like a subset, and that's like a function of all of the problems with insulin and then all of the problems with the vascular problems from that standpoint there. So again, like I said, guys, I'm not even sure. You used to tell me like a little timer how long I'm doing this, so I'm not even sure how long we're doing this. But first of all, I want to thank everyone who joined in on the Lunch and Learn. Thank you for liking, thank you for sharing. You guys' support is much appreciated here on this, and as very excited. This is our first, I guess, educational Lunch and Learn here in the new office. Like I said, we're trying to do it like we did about 1:30. Ish today. It looks like about 2:11. So hopefully we can kind of get to that same time frame every Tuesday. We no longer do Lunch and Learns twice a week now. What we're doing is we're doing the Lunch and Learn, this video version, on Tuesdays, and then on Thursdays I'll have a podcast version of the same lecture. And like I'm gonna because I can watch this, so I'm gonna re-record it and do it more for the podcast format aspect of it. But it'll be a podcast format. So let's say you don't have no time, you're working, you don't really have time to sit there and watch this video. You'll be able to listen to it on a podcast. And again, Lunch and Learn with Dr. Barry, it's on iTunes, Apple Podcasts, Google Play, Stitcher, SoundCloud. So all of your favorite, podcast listening sites. Or if you want, I'll have a player on my website as well that day. So Thursday morning ish, you should see a new episode, and it'll be, Lunch and Learn. It'll be on diabetes and like why is diabetes so important from that standpoint there. But again, I gotta run. I'll see you guys later. Thank you guys for all the support, and you guys have a great and blessed day. Bye.